This morning, it is my great honor and privilege to introduce my good friend and colleague, Dr. John Pennycuff. Always one that's willing and eager to go into our GYN ORs and help us out. He's also been found boldly going where no urogyn has gone before, the labor floor, which I feel like we're going to hear a little bit about today. Dr. John Pennycuff is an MD, MPH, and an assistant professor at the University of Wisconsin, and an associate program director for the formerly known as Female Pelvic Medicine and Reconstructive Surgery Fellowship. And I just have to say, I think it is so fitting and hilarious that you guys have changed your name so many times and landed on the acronym ERPS, but that's just side note. Anyway, we're not, I know, but come on, it's kind of funny, right? All right. He's board certified in obstetrics and gynecology, as well as formerly known as female pelvic medicine and reconstructive surgery. He sees patients at UW Multidisciplinary Women's Pelvic Wellness Clinic. He graduated from Vanderbilt University and holds a master's degree in public health from Tulane University. Dr. Pennycuff attended medical school and OBGYN residency at Emory University. He completed his fellowship at Georgetown and MedStar Health in Washington, D.C. His research interests include pelvic health and sexual well-being among survivors of breast and gynecologic cancer, implementation of subspecialty surgical care in rural populations, and supporting the early career of surgeons. While he is an accomplished urogynecologist, I think my 5-year-old summed him up best when she said, he's the funnest. So please, let's all do a couple Kegels and welcome to the stage, Dr. John Pennycuff.
Okay, good morning, everyone. That was a very nice welcome. Thank you, Laura. I really appreciate it. I am going to get started by, first of all, welcoming the new interns. Welcome to the first month, but you don't have to know anything. It's lovely. So I actually had one of you in my OR yesterday. Yes, hi. It's Jess, right? Yeah, thanks for coming in. So interns. The good news is I'm going to ask you, I have to say it by the mic. I'm going to ask you some questions and the audience as well. And the good news is there's not a right or wrong answer. So you can't screw this up. Okay, you have a patient. She is 32 years old. She has prolapse, comes to you. She definitely wants 2 more kids. We offer her prolapse surgery. We don't offer her prolapse surgery. If we offer her prolapse surgery, raise your hand. So we don't offer her prolapse surgery. We don't. Okay. All right. Interesting. I'm hoping that perhaps after this talk, we maybe have some more hands at the beginning. Okay. So these are my disclosures. What I hope to discuss today is the epidemiology of pelvic floor disorders among women of reproductive age, discuss the evidence of outcomes for pelvic floor surgeries after pregnancy and delivery, and then discuss the evidence and recommendations regarding mode of delivery after pelvic floor surgery. Okay. Oh, Lord, I'm going to mess this up. Okay. So there are many factors that sort of can play into pelvic floor disorders that occur as a result of pregnancy and delivery. You know, we often think delivery is sort of the trauma that causes pelvic floor disorders, particularly stress urinary incontinence and pelvic floor disorders. But the truth is the pregnancy in and of itself can cause pelvic floor disorders. In fact, there's a big Kaiser study that looked at women who were pregnant and got an abortion in the first trimester versus those who had never been pregnant ever. And women who had been pregnant at least one time were more likely to have pelvic floor disorders than those who had never been pregnant ever. And the thinking is that there are hormones associated with pregnancy, both early and late, like progesterone, relaxin, these types of hormones that sort of change collagen synthesis and change the support of the pelvic organ support system. There's also nerve injury and muscular damage. It's not uncommon for, to be on labor and someone says, oh, you saw that baby coming under the, that's the baby coming under the arch. Nope, that's the perineal body ripping away from the rest of the, the vaginal support tissue. It's not uncommon to have levator avulsion or levator injury or nerve damage, which also can contribute to things like stress urinary incontinence and pelvic organ prolapse. And then, of course, me, I'm in the room, so probably there's a 3A or a 3B or a 3C perineal laceration. So that obstetric trauma also contributes to pelvic floor disorders down the road. Let's see if this plays. This is not going to play. That's okay. So this is how people used to get information about healthcare for those, the interns, who's the new generation. This is called an ad, all right? And it played on TV, typically late at night because it was older individuals who were up late at night because of their urinary incontinence. And so this would be targeted to that generation. Now we have the things like social media, like Insta, TikTok, and the algorithm. So what we're seeing now is this is how people are getting targeted ads. And what's happening is the narrative is changing in urogynecology and in gynecology in general. Before, a patient would come at 60 years old with pelvic organ prolapse or stress urinary incontinence and say, I had no idea that treatment options existed. And now patients are coming to me at 20 and 30 years old and saying, how do I prevent pelvic floor disorders? Or, hey, I want to be treated because this is bothering me. I can't do the things, I was doing my inverted lotus pose at hot yoga and I leaked and that's not okay. And so, or CrossFit, right? Like I was doing this high impact activity and I feel pressure and it's really impacting my day-to-day life. And the people who are doing a great job at targeting patients are actually the PTs. I wish I could say that the doctors were doing a good job, but the PTs are doing a spectacular job in terms of providing really evidence-based, objective, really good information on like TikTok and Instagram. So pelvic floor disorders in the United States, we sort of think of it as something that occurs in like maybe our mom or our grandma. But the truth is 20-year-olds, 30-year-olds, 40-year-olds, women of reproductive age do experience pelvic organ prolapse, urinary incontinence, fecal incontinence. So like in a woman who's in her 30s, about 15% of them will have one or more pelvic floor disorders compared to almost a quarter in their 40s, right? And women are getting older in this country. They're having babies at later age. So it, the Venn diagram overlap of having a baby and having pelvic floor disorders is sort of, that overlap is widening. Here maybe a little bit less, but in Washington, D.C., where I came from, the average age of a parturient in our hospital is 37 years old. So you go to some hospitals in California, it's 40. So like, I think sometimes you might be thinking, oh, this is just the one or two off patients, but the truth of the matter is it's much more common than we think. This is, again, prevalence of urinary incontinence is quite high among women of reproductive age. And I just want to really make sure that we don't sort of leave thinking that incontinence or pelvic organ prolapse or fecal incontinence is just something that we see in women who are 60, 70, 80 years old. Okay, so let's start with probably our most well-studied, one of our safest, most effective interventions that we've had, the mid-urethral sling. The retropubic mid-urethral sling was brought to market in 1996. It was developed in Sweden, and since that time, we've placed more than 6 million worldwide, and we have so much data on this. So your patient's a 32-year-old gravid 2 para 2 delivered 8 weeks ago. She presents to your office with stress incontinence. She would like to know more about treatment options and is interested in a sling. She saw something on TikTok. She's not sure if she and her wife are going to have more kids, but it's like maybe on the radar, okay? So if you read the IFU, which is the insert that no one reads, right? Like if you open up a bottle of Botox, you open up a sling, right? It's like 76 pages. It was written by lawyers. I don't understand it. We throw it away. But if you actually read the IFU, it says a contraindication to placing a sling is pregnancy or considering becoming pregnancy. So surgical treatment for stress urinary incontinence and mixed urinary incontinence has generally not been recommended before completion of childbearing. And so this comes directly from the Advantage Fit sling that I use, the IFU. A mesh implant is contraindicated in pregnant patients. Okay, that makes sense. I think we can all agree there. Patients with the potential for future growth. Okay, so we probably want to put it in a 2-year-old. And patients that are considering future pregnancies. I disagree with this. And I hope by the end of the case, you all will say, okay, there is some evidence to suggest that maybe this is not true. Prior to 2018, we didn't have any large studies, only case series, but since that time, we've had more data. Take a little sip. Okay, so most of our data that we have on this topic comes from Scandinavia. There's a reason. The Scandinavians are really good about like tracking everything. You are essentially the thousands and thousands of data points from the time you are born till the time you die. And so what happens is there's a birth registry and there's a medical registry, and Scandinavia is really good at linking them. So the Swedish medical registry study linked the patient registry, which is your medical registry, and your birth registry. And they looked at people who had a birth or no birth after a transobturator or retropubic midurethral sling. And they, of course, this was a well-done study. They had one case and they matched you to a maximum of 3 controls based on how old you were at the time of surgery and the year of surgery. And then you were asked to complete some standardized, some validated questionnaires. The UDI is a 6 questionnaire that looks at urinary incontinence, and the IIQ is a 7 questionnaire that looks at how much incontinence affects your day-to-day life. So they had a pretty big study. They had mostly vaginal deliveries, mostly cesarean deliveries, and then followed by vaginal deliveries. And what they saw is whether you had a C-section or a vaginal delivery after your sling, about 25% of the there was about 25% of recurrence in your stress urinary incontinence. This is sort of what we say, right? Like we say that your cure with a sling is about 80%. That's what our big studies say. So it's not surprising that maybe some patients have some stress, like about a quarter of patients have stress incontinence after a sling. And what they found is it didn't matter whether you had a vaginal delivery or you had a C-section. Like it didn't affect your recurrence, okay? But interestingly, the reason that the patients had a C-section was because they had a sling. C-sections, as I don't have to mention to anyone in this room, are not benign surgeries. They are big, major abdominal surgeries that have implications like bowel injury, adhesive disease, ureteral injury, placenta accretive spectrum disorder, right? Like we know that C-sections are not benign, and for the patient to say, I had a C-section because I had a sling placed is a little bit troubling. So again, what they did find is that BMI, so BMI greater than 30, and they found that needing like some psychiatric disorders were also associated with incontinence. And this will come into play a little bit later on, and I want to make sure that we mention it. The same study was repeated in Norway. Sweden got on board, Norway felt left out. So they repeated the same study in Norway. And basically they found the same thing. They looked at birth versus no birth after any type of midurethral sling. They attempted to do matching in a 1-to-3 basis, just like the Swedish study, but they were only able to do it in 1-to-2. And they compared responses to these validated Norwegian incontinence questionnaires before surgery, and then 6 to 12 months after the sling, and then at the time of enrollment. Again, 72 cases, 156 controls. Cases tended to be younger and had lower parity. That makes sense, right? Because we're looking at women who might want to have children in the future. So they're going to be younger and they're going to probably have lower parity than those women who say, hey, I've completed childbearing. They're going to be older and have more children. And they had follow-up time for about 10 years. Like these are studies that we just could not do in the United States. So we're very lucky that Scandinavian countries have set up such robust data repositories for us. They found, again, similar recurrent SUI rates, similar to what we found, that patients were cured 75 to 80, 80% of the time, and that women with 1 or more delivery have higher recurrence. But that's not necessarily delivery after the sling. It's just that the higher the parity, the more recurrence you had. Mode of delivery did not impact outcome, and pregnancy-related complications attributed to the sling were rare. Interestingly, anytime there was a urinary sort of complication like a UTI or retention, it was attributed to the sling and not pregnancy. So, I think, again, this study probably inflated complication rates. Does that kind of make sense to everyone? People who are pregnant get UTIs, right? We treat them. You guys, I don't anymore, but I did at one time. And I remember we treated a lot of UTIs and a lot of asymptomatic bacteria. I imagine that hasn't changed in practice, although it has been a minute. Again, you see the same thing. BMI is associated with incontinence. Parity before midurethral sling is associated with incontinence, and then needing a repeat operation is associated with incontinence. Well, probably needing the repeat operation is because they had really bad incontinence and the sling wasn't enough, right? So are we starting to see a picture? I promise we'll get out of slings eventually, but I really have to beat this dead horse because then they did the same study in Finland. Okay. And I won't go because again, Finland felt left out. But what's really cool about Finland is known for really great maternal and child outcomes, and they do a great job of studying maternal health. Finland's the country where you get the box, whether you're rich or poor, everyone gets the box of everything you'll need to take care of that baby in the first year of life. And that's why one of the reasons why maternal and fetal and infant outcomes are so good. So of course they would, I think it's no shock that Finland would get on board. Again, same study, their primary outcome was retreatment for stress urinary incontinence, not recurrence. And basically they found the same things. Cases had higher parity. They had more vaginal delivery because again, Finland is more known for vaginal delivery in the OB world, and they have very, very low C-section rates and very, very low rates of perineal laceration. Similar follow-up time. Retreatment was very, very low. Again, this is kind of what we see in the United States. Patients get slings, they're cured about 80% of the time, very little retreatment. Most important is that pregnancy did not have like a high complication rate and that mode of delivery did not affect the rate of retreatment. So these are some takeaways. I think you remember my takeaways, but now I want to show you, okay, this is the best study ever. When you can publish a study that's a study, but no one's ever published it before, that's the study you want to publish because this study will be cited forever. Someone was like, oh man, all these Scandinavian countries did all these studies. I'm going to do a meta-analysis. And now no one will care about these registry studies. They will always cite the meta-analysis because it's such robust data. So for those in the room that may not be as familiar with forest plots, the forest plot is sort of the statistical analysis that we use in meta-analyses. And basically the dots, the individual dots, in this case, the blue dots, the blue squares, are the different studies. The size of the box of the square tells you the effect size, and the line that goes through the box tells you the confidence interval. And the line that goes up and down the middle at 1 tells you, to the left, it's childbirth, and to the right, it's no childbirth. And so the studies show you what the effect that childbirth had on patients who had these slings. Then they pool everything together and they give you the diamond at the bottom, and the diamond tells you sort of if your risk for recurrence of stress urinary incontinence or risk of retreatment favors childbirth or no childbirth. And you want to see, does it cross 1 or not? So basically, the first forest plot tells you that if you got a sling and then you had a baby afterward, or whichever way you delivered, does not affect your sling. Okay, then you got another. The next forest plot is for reintervention, right? And that again does not reinvented intervention rates were not higher among women who gave birth or not, right? So what we're seeing is that you can get a sling and you can have a delivery, and it can be vaginal or cesarean, and it should not affect your sling. This final is women who had a vaginal delivery and women who had a cesarean. Your mode of delivery does not matter. It will not affect your sling, whether you have a vaginal delivery or cesarean delivery, okay? And then again, this was stress urinary incontinence reintervention rates did not matter whether you had a baby, whether you had a vaginal delivery or a cesarean delivery. So your recurrence is not affected by whether you had a child after a sling or not. Your reintervention was not affected by whether you had a child or not. And then vaginal or cesarean, it doesn't matter, okay? So what does matter is if your BMI is over 30, that increases your risk of incontinence after a sling. And then what they found is that if you had urinary incontinence before pregnancy or during the pregnancy, you are more likely to have urinary incontinence after the sling and or after the delivery in the setting of a sling. Does that make sense? Right? If you had it before, you probably were going to have it after, right? Okay. So really, we shouldn't be worrying so much about how patients deliver or whether they get a sling or not. What we should be worrying about is helping them lose weight. Okay. So there are other obviously retropubic procedures like colposuspension and pubovaginal slings. These are like slings that we make by harvesting your own fascia. And then augmentation cystoplasty, that's where we help We put like a little piece of bowel to help the size of the bladder. Really, we have no data for those, except we do think a vaginal delivery is safer for augmented bladders because that bladder is so fragile, you wouldn't want to accidentally get into it when you're doing a C-section. Okay, so let's move into sacral neuromodulation. This is pretty rare, but there are young women who have something called Fowler syndrome. And this is urinary retention. We don't know what causes it, but they get sacral neuromodulations, but it's always in young women. So it's not uncommon that these women might become pregnant or choose to become pregnant. And so the patient has this. She and her partner are considering starting a family. She wants to know if pregnancy will affect the device and what she needs to know about delivery. Well, we don't really know how sacral neuromodulation works. We think that the mechanism of action is modulating excitation inhibition between the bladder and the spinal cord. And so there are theoretical concerns for uterine contractions and preterm delivery and miscarriage because you're sharing the same neural plexus. If you're exciting one area, you might then be exciting the uterus. And basically what we have seen on studies, like ultrasound studies, is there is some tonic activity of the uterus when sacral neuromodulation is functioning. So animal studies, though, have not been shown to increase miscarriage or teratogenicity, and we obviously can't do these studies in humans. I can't randomize women to getting sacral neuromodulation or not and seeing if they miscarry. So the biggest study was done by Maran. Again, 22 patients with 26 pregnancies, not a huge study. The recommendation for the company is that you deactivate the device in pregnancy. So two of the women found that their retention returned. It was so bothersome that they asked for reactivation. There was one miscarriage. And this was in a patient who had IVF, and her device was deactivated prior to transfer. So we don't think that we can say that the sacral neuromodulation was responsible for that. There were 18 term births, 7 preterm births, and if you look sort of like in the United States, what percentage of births are preterm, this follows sort of the normal percentage of what we expect in preterm versus term births. Again, can you draw any conclusions from a 22 patient study? No, but we can at least say, they followed general trends in what we would expect in the United States. And then 2 infants did have birth defects, motor tics and pilonidal cysts, and both parents also had those same birth defects. So, we think that that's probably more related to genetics and less to sacral neuromodulation. In terms of how the devices functioned after delivery, so interestingly, about half of the patients had functioning devices post-delivery. Some needed reprogramming and some needed a revision. But generally speaking, we can say that it's pretty safe to have these devices on if a patient's really bothered. But it's really about counseling patients on the risks versus the benefits and their quality of life. Of course, the companies always recommend turning off the device in pregnancy. And in terms of how we would deliver these patients, there's insufficient evidence to recommend a mode of delivery, but the International Urogynecologic Association recommends mode of delivery be based on maternal and obstetric indication. So same thing, pelvic organ prolapse. You have a 42-year-old. She comes into your office finding out that she's pregnant. She had a hysteropexy a couple of years ago for stage. I mean, these are real patients. These are patients I've actually seen. And she would like to know how she should deliver and if her prolapse will come back. Hysteropexy is increasing in the United States. We don't see, it's really geographic based. We don't see just a ton of it in the Midwest. Women sort of are like women in the South. I have prolapse, it's time for hysterectomy. That's sort of the general narrative. But if you go to the East Coast or the West Coast, hysteropexy is a very common. And I have European patients who basically are like, I want a hysteropexy because that's what we do in my home country. In the United States, it is increasing. And then we also have increasing maternal age and use of IVF. So it wouldn't be unreasonable that patients who had a hysteropexy might get pregnant. We also have had some change in reproductive rights in this country. I don't think that's news to anyone. And so unintended pregnancies and the ability to sort of handle those unintended pregnancies, I suspect, are on the rise. We only have case reports and case series. All deliveries have really been via cesarean delivery, but overall good outcomes. So I think we can say to patients, we would anticipate if you sort of had a native tissue, like using your own tissue and suture hysteropexy, probably going to have good outcomes. But interestingly, there was one study with 3 pregnancies, or one series with 3 pregnancies. All the pregnancies were terminated, and 2 were terminated due to concern over recurrent prolapse. So when I do a hysteropexy in a patient that wants a hysteropexy but does not want to be pregnant in the future, I try to remove tubes if possible. Sometimes you can get them in the posterior cul-de-sac, because there is some thought that, patients may want to terminate or may be concerned about mode of delivery because of a recurrence of prolapse. This is one of our largest studies that we have. They were patients that underwent a posterior sheath sacral hysteropexy. Uterus is kept in place, mesh is added to the back of the vagina, and then tacked to the sacral promontory. And so there were 8 pregnancies. One was a miscarriage, 7 term births, and they were all delivered by elective cesarean delivery. And then most of the patients did not have recurrent prolapse. Generally speaking, same thing when we do native tissue. We don't have a ton of data for this. So the things that we need to think about, or the things you might need to think about, are the theoretical concerns about changes to the uterus, that if I put mesh on the uterus or mesh on the vagina, how that might affect the uterus as it grows. Could that result in growth restriction? We don't know. Also, mesh makes things rigid. That's why we use it, right? That's why I use it in patients with advanced prolapse. I want there to be more structural support. Well, if you make the uterus rigid, how is it going to contract? There are also some concerns about tensioning on the sacral promontory, leading to pain. When the gravid uterus grows up and tips forward, prolapse tends to get better in pregnancy if patients have it. Well, there's some concern that as it grows and tips forward, it might tug on the sacral promontory, causing pain or eventual avulsion. And then we don't have enough evidence to say this is how you should this is how you should deliver regarding mode of, this is how you should deliver because you had this surgery. So, I think we just say it's based on maternal and fetal indications at the time of labor by your L&D provider. There is some concerns about the Manchester procedure. There's probably only a handful of people in the room who know what the Manchester procedure is, but it's kind of like we kind of start like if we're doing a vag hyst, and we sort of plicate the uterosacrals, and then we sort of lop off the cervix. And it's a really good procedure for patients that are really sick, that you don't want to do a hysterectomy on, that like really can't tolerate a big surgery. They do a lot of them in Holland and the Netherlands. And so our studies come from the Netherlands. They love them there. But because you are transecting the cervix or potentially affecting the cervix, that could lead to preterm birth or miscarriage. Okay. Rectopexy, I'll just skip over it because I want to really focus on the other things, but rectopexy, this is actually what started this whole presentation. As I had a colleague, it was actually Laura, who's like, I have a patient with a rectopexy and she wants to know what's going to happen if she delivers. They have actually the colorectal surgeons have better data than we do. Basically, we don't think that pregnancy and delivery affects the rectopexy. Most patients are delivered by a cesarean delivery. And afterward, there was no change to the Longo or Vasey scores, which are validated questionnaires that look at fecal incontinence. This is really a place where if you were interested and wanted to do a study, like if one of the residents wanted to do a research study, there's a dearth of research in the colorectal literature, and they would love to be able to publish more. And so I think this would be very publishable. Okay, so I want to talk a little bit. I think, I love perineal lacerations. I love seeing the patients. Honestly, it makes me so happy to have these patients come and they're 3Bs and they're all scared and they're like, oh my God, this is terrible. And then they see me in perineal laceration clinic and I really don't do anything. I just tell them everything's going to be fine and you did great and the baby's cute. And we're going to just watch that perineal laceration and I'll see you in 6 months and they feel great. But one of the things that I think maybe many people in the room wonder is, how should I counsel patients who maybe had a 3B? What's their risk of recurrence? What do I tell them for how they deliver next year? And so a perineal laceration is pelvic floor surgery. When we fix it, that's pelvic floor surgery. And that's probably the most patients that we have that get pelvic floor surgery that then are going to go on to have another baby. So this patient's the 35-year-old gravid 1, pair 1, 7 months post-vacuum associated delivery. She's complicated by a 3C. Again, these are all real patients from my clinic. She wants to know what's her risk of another obstetric anal sphincter injury and should she have a C-section for the next delivery? Okay. We expect that the rate of 3s and 4s is about 2 to 4% across the United States. The study is in the Green Journal by Friedman et al. It's an amazing study. It's very, very elegant statistics that they did. But basically, it doesn't matter what hospital you're in general. It doesn't matter whether you're in community or academics, rural or urban. The rate of 3s and 4s is about 2 to 4%. About 3% 3s, 1% 4s. And the biggest risk factors are operative vaginal delivery and shoulder dystocia. And there's little hospital variation throughout the country, okay? Early studies said that risk of recurrence was up to 21%. So if you had, in G2, your risk of a recurrence of your perineal laceration was 21%. But this study was done before we did as much restrictive episiotomy use as recommended by ACOG. And so what we actually find now, when you look at studies that are sort of in contemporary obstetrics, your risk of recurrence in G2 is about 7 to 8%. So you can counsel patients who had a third or fourth in their first pregnancy that their risk of recurrence is 7 to 8% in their second. But that also means that their risk of not having a perineal laceration is 92 to 93%. And so when patients come, I make sure that they hear both of those, because a risk of recurrence of 7 to 8% sounds great. I would play the lottery if my risk of winning the lottery and like Powerball and getting that $360 million or $1 billion or whatever, if it were 7 to 8%, I would play every night. And I'm going to be honest, Ellen, if I won, it would just, I'd be out of here. I'd be on a beach somewhere. I don't know you even get a phone call, because I would love to win $360 million. But that's not right. Those are good odds. But I would definitely play the Powerball if my odds of winning were 92 to 93%, right? So I think it's really important that patients hear both sides of it, right? Your risk is 7 to 8%, but your risk of not having a tear like this is 92 to 93%. Okay. Patients wonder, well, like I had no problems in my first delivery. What's the chance that this would happen in my second delivery? It's between 1 to 2%, so a little lower than sort of general population. The risk, if you had a perineal laceration in G1, you're pregnant again, your risk of an elective cesarean, remember cesareans are not benign procedures, your risk of an elective cesarean is about 25%. Okay, so and for that indication, so patients who had a perineal laceration and then go on to become pregnant, about 25% of them will elect an elective cesarean. If you ask colorectal surgeons how they would deliver, 70% would say by elective cesarean. 22% of obstetricians would say by elective cesarean to prevent oasis recurrence. I think this is because of our perspective, right? It's rare that a colorectal surgeon's in a big placenta accreta cesarean hysterectomy, right? But they are sort of, their view is peppered by fecal incontinence and sphincter disruption all day long. Whereas we see those big abdominal surgeries and the loss of the blood. And I think we have a better understanding of what a cesarean actually is. So I think it's important to remember your biases as you're counseling patients. There's a big analytic model that looked at elective cesarean after oasis, and what they found is that the all-comer morbidity rate for C-sections is about 11% compared to 4% for vaginal delivery, right? So your complication rate is 3 times higher for a C-section than a vaginal delivery rate. And we're looking at this through the lens of trying to prevent obstetric anal sphincter injury. And that your relative risk of a maternal death is 2.6 times higher for cesarean delivery than vaginal delivery. And this is exactly how I counsel patients. I use these numbers and I say these numbers so that they get an understanding. If they're going to elect for a cesarean delivery and bring that up to their obstetrician, the first thing I say is we don't have good evidence. We don't have high quality evidence. And it's easy for me to sit in my comfy office 9 to 5 and tell you what the data says, but that obstetrician who's actually managing your labor at 2 o'clock in the morning, their decision with your counseling and informed decision is really, that's how you make a decision on how to deliver, right? I could say C-section or vaginal delivery, but I'm not the one doing it. And obviously for maternal and fetal and obstetric indications. So these are the numbers that I use. This is what I quote. And I think it helps patients understand, like, if I'm going to choose a C-section, I do have more risk. What does ACOG say? Well, up to 90% of women who had a previous OASIS will undergo a subsequent vaginal delivery, and that you have to balance the risk of cesarean with overall risk of OASIS recurrence. And basically, ACOG says that if you had a primary repair that required a secondary intervention, like a breakdown infection, a sphincteroplasty, a delayed sphincteroplasty, those patients could consider an elective cesarean. I would suggest that if they had a delayed sphincteroplasty or some sort of secondary intervention, that they should consider a cesarean. If they are still having symptoms, like they're still fecally incontinent, you would want them to not deliver over that tissue, because that tissue becomes further traumatized and devitalized and may worsen their symptoms or make a future repair difficult or impossible. Or if the patient expressed psychological trauma and would not want to have that same psychological trauma again, they could request a cesarean delivery. And sort of I think that that's reasonable. There are a lot of patients. There's a study we're actually doing with our fellows is looking at PTSD scores in patients that have had perineal lacerations. So then the question is, I'll just wrap up, choosing the next mode of delivery. So if your patient had an obstetric anal sphincter injury, it was repaired primarily on labor and delivery, and that patient is asymptomatic, presumably they have an adequate repair, they have an intact anal sphincter, by all means, a vaginal delivery is certainly indicated. We know they're much safer, and they're often the preferred route of delivery for patients. If they do need an episiotomy, please cut a medial lateral episiotomy. Residents, please learn how to do medial lateral episiotomies. I know that they're harder and there's more blood, and there's more pain, but they will protect the sphincter. And then the thought process, and the people who are really study this are in London, Renee Takar and Abdul Sultan, and they basically say that we should consider a cesarean delivery if a traumatic birth is anticipated, like macrosomia, OP, prolonged labor course, or need for operative vaginal delivery. Again, I'm not the one that's doing this. I always say it's between you and the obstetrician at the time of labor and delivery. But if there is a history of obstetric anal sphincter injury repair and the patient is symptomatic, we would really want to offer cesarean delivery to prevent further damage to the anal sphincter complex. The idea is that we don't want to further devitalize the muscle or the nerves, because eventually we'd like to do some sort of repair, potentially for that patient. And then they can delay surgical treatment of their obstetric anal sphincter injury if they're symptomatic and they want future fertility. That's really important to them, or they can go on to, they can have the repair as well. So I would like to thank you for your attention. I hope everyone learned something. And I hope that we've changed our practice enough that we could consider surgical treatment of pelvic organ prolapse or stress urinary incontinence in our patients who might be wanting to grow their family even more. And I'm happy to take questions at this time.
Thanks, John. Going back to those slides about hysteropexy, with or without mesh, and a patient is pregnant, has a history of a hysteropexy, makes it to like a gestational age where delivery is indicated. So she's like made it past, her uterus like growing and everything else. Is the idea behind like this, because everybody was in that study was recommended, or everybody had a C-section, right?
Yeah.
So is the theoretical like thinking behind that there's concern for just like a failed trial of labor because of that pexy? Is it like concern for some complication like uterine rupture or like something bad, or is it concern about damage to the pexy and needing like reoperation later?
The answer is yes.
Okay.
So interestingly, those studies were not done in the United States. I also think when you sort of step into some of the places where those studies were done, a C-section is sort of seen as more of like the wealthy get C-sections, and I think there's a cultural sort of implication in those studies. I think that's like a sort of a subtext. So that those patients may have gotten C-sections as well, just in general. But the idea is that, so let's say you get a patient at 38 weeks with a hysteropexy. The idea is, will she have some sort of obstructed, and I don't know if this is the word that is used anymore, but obstructed labor because she can't contract because the mesh is affecting that. And then we shouldn't even let her trial of labor. Will her labor sort of not fall on the normal Zhang labor curve and she falls off and so she's gonna sort of have a failed trial of labor anyway. And then it's, yeah, she's gonna labor, push, something's gonna happen. It's gonna rip off the sacral promontory. The thing is, if it's gonna rip off something, it's not gonna rip off the sacral promontory. It's gonna rip off the vagina, rip off the uterus, which is not ideal. But that's where it rips off. So that's what the concern is, right? It's gonna rip from its attachment. And I think also these patients were like, I have this repair. I don't want to deliver vaginally because I have the repair for the prolapse and I don't want the prolapse to come back. So I think it's all of those things. I would say, based on the available data, I would say there's not enough data. And like, what's important to you? Do you want to do a trial of labor? That's really important that you have a vaginal delivery. Certainly you can try it, but I think your level of suspicion would have to be very high. You know, I think that's if there's mesh. I think if it's just a native tissue, I don't know, Dobie, Caroline, what do you think? I think if it's just a native tissue, that's sort of the same, like it's the same. It's like anatomically the same. If there's mesh, I think your spidey sense has to be very high to basically call it and be like, we're not moving forward. The other thing too is when they do their posterior meshes, they often will bring like these little wings. They'll like you'll make a T and you'll cut into the broad ligament and you'll bring these little wings of mesh around to the front and it sort of makes a ring around the uterus. And I could see theoretically of like having like a stricture, like a cervical ring or something. And I think that would just, your spidey sense would have to be very high.
Okay, good. Thank you so much, Dr. Pennycuff. This was just, you know, just a fabulous talk. And I learned, I think, 3 things, maybe 5. But you know, case-based, you know, gave the evidence, but also gave people some really practical advice. So my question is about the 2 things I'm thinking about now that I haven't been thinking about are rectopexies and hysteropexies. But my question's about the rectopexy. So would your hypothesis be that once people study this better, that that you'll find the same thing you found with slings, that, you know, that you don't need to kind of quote, protect the rectopexy, that you basically should, you know, you wouldn't recommend or counsel against pregnancy or against or for elective cesarean. So, or do you think it's just that it's sort of a data-free zone and that your hypothesis would be that you would be getting to the same conclusion as you had with the slings?
Yeah. So, you know, the thing is, the rectopexy, whether you do it with mesh or whether you do it with suture, they elevate the rectum by attaching it to the anterior longitudinal ligament at the sacral promontory, much like we do with sacrocolpopexy. And I just can't see a physiologic way that like the uterus.
Why would it be different?
Yeah, why would it be
Why
different?
would it be different?
Yes, and I just can't, unless that baby creates a window, grabs the rectum and pulls it on the way down, right? Like it's just not gonna happen. So I just, you know, I think, you know, what I would like a takeaway to the trainees is we all need to practice evidence-based common sense medicine. And in the absence of evidence, practice common sense, right? Physiologically, it doesn't make sense that delivering would rip the colon off of the sacral promontory. It just doesn't make sense. Just like it doesn't make sense to give patients weight restrictions because like they're lifting themselves up. So you need to think about this. And so when I think it's sort of about the common sense things, I think this is like a does study. We're going to show that pregnancy and delivery doesn't affect it. It's going to be very publishable, very citable. And I just can't think of a reason why it would.
Yeah, that makes sense. Thanks so much for this.
Thank you.